which are extremely expensive. Then we'll take part of our saving or our part of our profits and we'll share them with you. So there's an incentive to the primary care physician to take care of his patients. Now, the ones that I spoke with and the data that we received, Mr. President, was the physicians like that because they don't have to herd people in like cattle and just see them and then it becomes a cycle of billing. It becomes a way to practice medicine the way that you're supposed to by keeping people well instead of just treating them and running them through this grindstone, this work. The other thing that Passport does is they negotiated down the dispensing fees. We pay $4 for every prescription that's filled in Kentucky except in the Passport areas. And they negotiated with some of the larger pharmacies and Walmart, and they've lowered the cost down to whatever it is, $1.50, $1.50, because they wanted the people in the store not to buy the drugs necessarily or get the prescription filled, but to buy the other products that are available. Now, if Walmart in Louisville will take $1.50, for an example, for a prescription for a Medicaid place, why won't it in Prestonsburg or Paintsville? The answer is it will. And that leaves open then the issue, well, what do you do with the mom and pops? Well, what they do actually is increase the rate a bit for the mom and pops because they are sort of at a competitive disadvantage, and it keeps everybody happy. I mean, to me, there was a lot of common sense things that, as we discussed the way they approached this whole idea, Bill, that made sense. And then when you look at the way that we've done it as opposed to the way that it ought to be done or some of the things that I believe can be implemented, in some states, you ask what could be done. In some states, not only are you encouraged to use generics, if the same product is available over the counter, Medicaid program does pay for it. Good example are the stomach medicines, the things that people have to take for constant heartburn. And so there's a lot of things you can do, and that will have to be done because we simply can't afford, like you can't afford. Every business I've ever owned and been a part of, I provided insurance for my employees like I know most or all of you all do because you get better employees. But every year, it's the same problem. How do we keep the same coverage or similar coverage and pay for it? It's just, there's got to be some way to cap these skyrocketing costs. I believe, and the President and I probably don't agree on this point, that the National Health Insurance Bill, once it's implemented, will be a cost containment measure because we're going to get a lot of people who currently don't have insurance out of the emergency rooms, and we're going to get them into a cheaper and less expensive form of coverage. We're going to have more people being paid, more people paying into the system, and so hence it should stabilize the market. But that's another debate for another day. But
it surely is, and you're right. We do not agree with that. But I will tell you one thing we do agree about is that a major part of the savings will be done with pharmaceutical management. Now we have we can do real-time looks at prescriptions that are happening with folks right now. But if we have a database, and I think that ultimately individuals will be assigned to a particular pharmacy, whether it's a chain or an individual pharmacy where they'll need to go to, and you can identify the people that are the top, by utilization, the folks that have the various maladies and utilizations and do interventions in their healthcare programs. And I am an insulin-dependent diabetic myself, and I know I manage my diet and my medication very closely and that sort of thing. And thanks to my doctors and the good Lord, I'm feel better than I have in years. But there are a lot of people that need extra intervention, especially if they're elderly, they're diabetic, they have other chronic diseases. And if you identify by the utilization of pharmaceuticals and other diagnoses these people and apply special management, we can save a lot of money to get them to podiatrists and other folks that they'll need with things that are going to happen. We've got to do that. We'll be able to have a better efficiency, but we'll have a healthier population, and we can use the money in a lot more efficient way. But there's a resistance. One of the other things in the leaky bucket questions was why do government programs seem to never go away? And it is because if the only tool you have is a hammer, the whole world looks like a nail. And to everybody that's in the Medicaid department, they think they're doing it well, and they're shooting the money out, and they're counting the number of people, and we're just going to have to do some tough love on it.
One of the other, yes, sir. Just as a sidebar, an interesting point, everybody always asks me, why can't we do something to stop all the fraud and waste in the Medicaid prescription drug program? They're taking Medicaid dollars and they're buying these pills and they're selling them on the illegal, on the black market. That is not true. We studied that when I was Attorney General. We looked at it. Dick Rhodey and I actually did the Casper legislation. The people that abuse the prescription programs pay cash. They don't want to get caught. And so what happens is, if they're going to get 3 or 4 prescriptions filled of a drug that they're going to take out and sell on the black market, they'll pay cash for that. They won't use their Medicaid cards.
No, it's an infrequent prescription that gets sold. On occasion, you'll have someone for some pain medication that will go and get someone else to go buy. I think the speaker is correct about that. But it's the other medications, not the scheduled medications. When you start talking about metformin or Actos or those sort of things, they're very expensive. And if you let people go through this chronic disease situation, they're all going to end up on insulin and other things if you don't do something about it.
The other part of this budget pie and the big bite is public employee health insurance costs. And in full disclosure, I am one of those public employees. But they've increased 174%, as you know, since the year 2000, compared with an increase of just about 100% in the private sector. So to public employees and to business people and to others who are paying the bill about the health insurance changes that you enacted in this budget, and could you tell us a little bit about that? And
could I address that first?
Sure.
Okay.
Yeah, and Ken, but I want to, if I can, just ask you to also address part 2, and that.
I don't want to do part 2. Go ahead.
Okay.
Let me do part 1.
Okay.
I want to commend, and you won't hear this very often, but I want to commend the Speaker and the House of Representatives for exhibiting a tremendous amount of courage for coming forward in their original budget proposal with a delineated health insurance program that they included in their budget and that we passed in the Senate budget during the regular session of the General Assembly. It was a very good program. And there are several things that it included in there, and that is that we improved the basic program for state employees, teachers, and retirees. We improved the basic program in order to draw more people into the basic program so that there would be a greater efficiency there. And we decreased the supplementation and the subsidies we were paying for the higher end programs. And because the employees that were making more money could afford to pay that extra money if we wanted. And we put forth a program that by LRC estimates would have saved around $100 million and would have stabilized, because we also did co-insurance in addition to co-payment, which has been a tremendous issue. And we passed that, and when we came back for the special session, the governor included that provision in the budget. Of course, that's because he virtually copied the Senate budget, but that's another issue. And we passed it, sent it to the House. It didn't make it through the first time. There were some issues over there, but we agreed and put it back in the final provision that we did, and the Speaker was very instrumental in doing that against some opposition from public employee groups that are a bigger part of his constituency than they are the traditional Republican constituency. And then, lo and behold, the governor vetoes it.
That's question 2.
Okay. Well, I will answer that question. And, I thought that this was the most important, probably the most important fiscal issue that we addressed in this session in a very difficult situation with the House, the Senate coming together, the governor coming back, and there was never any explanation. There was never any call. There was never anything that I got. I'm sure that you and the governor talked about. But
Don't be so sure.
Yeah. And now, Bill, we're faced with a situation where we have priced and included in the budget a health insurance plan, and the governor, under advice of this advisory group, is going to have to come up with another plan now. And And he might do the same thing they did with the passport, is like give up the ghost and go ahead